and I think we are in the right direction. So, Dr. Gugino will make a brief introduction for us before Dr. Edgren come here as a first speaker. And Gugino, I'm really happy to have you here. I also, yesterday, he shared with me and Flavio a little bit of his presentation, and I'm sure you guys are going to like this introduction. So thank you, Carl, for your coming and for your, energy and everything for us. You're our mentor.
Okay, thank you. I'm just going to try to do a little overview here, and we'll kind of go along until some people start coming. So there's some people here for the real speakers. There's so few people here. So we'll kind of use this kind of as a chat to go through things that I'm thinking about. And this is the fourth meeting of this group. I want to thank Rocky Mountain and Tony Zackham and Adam Pollack for really helping put these meetings together. I think it's really helped. I began teaching in France in 1964, and it was really Rocky Mountain that started this whole thing in Europe, around the world, and the guy that did it was Martin Hamilton. And the first computerized cephalometrics we did was also with Rocky Mountain, and the Millennium, which we did, later was taken over by Rocky Mountain. So many of these things that we started years back, Rocky Mountain has been involved in and really helped with. We have a study club still in Japan, and the Japanese club is unique in that they have 650 cases presented. We do it at this BSC day every year, and their cases are presented and worked up like you see here. All mounted casts, frontals, laterals, etc. They're worked up beautifully. We have 650 of those. We have the French group, and really there's a new president who is Maxime. I don't have a picture of him. And the Italian group is hanging on by a thread. So but maybe that can get revitalized also. A special thanks to Flavio and Nelson and Bundy for really all the hard work they're doing in putting this together. And really, they are really working at it and working very hard. And they're traveling, they're working around the world to try to do a lot of this, and you got to really give them a hand. And the speakers they put together for these meetings have been great. This was our first meeting at the University of Chicago, which is really where Ricketts went to school, and they're both involved there in teaching, all three. And the next one was in Philadelphia last year, and then in Brazil. And that was a surprise. I mean, there is a group in Brazil, there must have been, 350 real bioprogressive people, and several textbooks, and it really this is one of the textbooks that Mario here did that's very nicely done, and there was another one given to me by, which is equally well done. Unfortunately, they're only in Portuguese, but they're beautifully done and so forth. So, you've read and you'll see these, and I'm sure you have them in your handout, but this is their mission statement and their vision statement. And this is the things that they're really trying to do and working very hard to do it. I'm going to talk a little bit about future possibilities. Everybody that's been involved in bioprogressive, everybody that's been involved with Ricketts and Bench, I really have a passion for excellence. And we better return to that if the orthodontic specialty is going to survive. What I feel is in the future marketplace, there's going to be several tiers of practice. There's going to be what I call a concierge practice, which is a lot what the MDs are doing in the United States. My heart specialist, for example, is now a concierge medical man, which means you pay to become a patient. $6,500 a year, you're a patient. You have 24/7 contact with him. You know, he's a very limited number of patients, a lot of personal communication, no insurance. So these concierge practices are going to be small practices, probably higher fees, and they're going to, I think, be here, but you can call them boutique concierge, what you want, but there'll be the smaller practices, and then there'll be the group practices, and then the corporate or franchise practices. And you're going to see more of these, because you're going to see dentistry going into the franchise business. And you're going to see corporations. And you're going to see dentists and orthodontists working for these corporations. You know, we usually follow what happens in medicine. And it's happening in medicine. Franchising in healthcare. It's boom time for this. And the doctors, many of them, are not so unhappy to go to work for these. You know, they can be well run. So, you know, because they have advantages in the reduction of paperwork, managerial duties, and they don't have to deal with the insurance companies because the corporation deals with the insurance companies. So, our goal in Bioprogressive is to aim higher to be exceptional. And our goal also today is to go from analog to the digital. So, just an overview of contemporary zero-based bioprogressive. You know, it's a patient-centered practice, service and health-based. It's a management concept. It's a systems approach. This allows a standardized way of incorporating new technologies, new appliances, new techniques, marketing, and management updates. You know, you have to think of all the things that are out there, that are available today, that we can, just a few, very, very few. But, you know, the cone beam is here, and it can be used, and you know, many men have it, but they really aren't using it to the maximum capability of what you can use it. And Dominic and I and Ivan Deuce introduced cone beam in 2002 into the United States. And, you know, there's a lot of criticism about it, still is. And you know, this is what we used to take for complete records. This is what you can do with one cone beam. You know, you can get all of this information with one single cone beam shot. So you're going from 2D distortion, really, to 3D reality. So you know, you can get all of this information really accurate, frontals and laterals. You know, one thing that Bioprogressive has always been in is the frontal X-ray. You know, Drain Grummins and Ricketts have kept that alive, and only 2% of American orthodontists use the frontal X-ray. And yet, with Damon and all the things they're talking about today, they're talking about the transverse dimension. They don't take frontal X-rays. So I don't know how they talk about it. But you can get all of this information, but you then have to use it. You know, I've heard about the medial and lateral pole for years, but you never could see it. You can see it routinely. So you can see these things. Yeah, the lights should go down. It'd be nice. Yeah. And but you know, airway, all the things that you can look at and see from one small cone beam. You know, you can look at each tooth, what you can do with each tooth, intrude, extrude, torque, whatever. So this is all available. The point is getting it in a position in your office where you can really use it to maximum efficiency. So this is what we can do with a lot of these things today. So the other things that are out there that really, you know, putting all of these technologies together is what I would like to really do as my kind of final hurrah in orthodontics. But, you know, moving the teeth, all of that, there's software out there that you can do almost anything you want with. And, you know, you can see moving the teeth in and out of the bones. You can really, you know, we need much more 3D thinking and much more 3D diagnosis and much more 3D visual treatment planning. The technology is there. It's that we have to ask for it and we have to get so we can use it and make it work in our practices. So there's a lot of technology out there. The big thing is getting it into your office, getting it to where you can really use it and use it to its maximum capabilities. Now, there's two other things that are really making changes, I believe, and that's the scan, you know, no more impressions. You can really, you know, with a scanner, there's many of them out there. They were mostly introduced at last year's AAO meeting and very confusing because there were so many different ones. You know, and Invisalign is using one now. And the 3D printers, you know, which is eliminating impressions, eliminating models. Again, it can be an in-house or you can send it over the internet to any lab. So all of this technology is there and we've got to see how we're going to use it. So it's also bioprogressive zero-base is a marketing concept and communication, visual and verbal, internal and external. And of course, this is all marketing and what we're doing. Mechanically, and it's really biomechanics today, a concept of individualization based on degree of difficulty. A concept of visual treatment planning, you know, and it should be 3D. A mechanical unlocking concept and a functional unlocking concept. So, you know, Gottlieb said in 2000, when he overviewed what happened in the last 50 years, the two individuals are exactly the same, and that we may be attempting to standardize the non-standard. And really, therefore, we must embrace individualization on the basis of degree of difficulty, of diagnosis and treatment design of the individual patient and their needs, therefore, zero-based bioprogressive philosophy. You know, these are what I think are really the three components of orthodontic treatment. And I think orthodontics today really focuses around this 5%. But diagnosis and treatment design are 75% of what you do, functional and mechanical unlocking 20%, and mechanics 5%. If you include the mechanical and functional unlocking, the biomechanics then is 25% of what we're doing. So this is a paper I gave in the American Association of Orthodontic Congress in 1972. And I called these basic premises. You know, 72 was really when the computer explosion was starting. You know, that's when the computers really started developing and going on. And these were my basic premises then. Our primary goal in orthodontics is a satisfactory outcome. Diagnosis and treatment management are merely the means to the end. Results come first. The question is, how do we get our best results? The practice of orthodontics in the future may be different from what it is today or has been in the past. What's happening? It changed very slowly from then till the 2000s, and then in 2010 it started to explode, and we started to see major changes. Orthodontics, being the oldest specialty in dentistry, should be the leader in initiating true preventive procedures for the future. We should be in prevention. Medicine is going into prevention. Success is a pattern, failure is only a few mistakes. Nothing will be accomplished if we look at every objection as something to be overcome. That happened then with supplementary, with visual treatment planning. Now it's happening with cone beam, etc. Early treatment has to be part of futuristic orthodontic planning. And really the bioprogressive movement was the only one that was really in early treatment in the United States. It is essential in true preventive procedures, and if for no reason, general practitioners and pediatricians will be doing it. Gotta remember, this was 72. And this is an important statement here, because there are going to be franchise practices. There are going to be group practices. There are going to be large practices. And quantity is not necessarily an enemy of quality if quality comes first. That's super important, because it's going to happen, but unfortunately, a lot of these practices are not quality oriented. Orthodontists need a better understanding in the field of communication with their associates, parents, patients, and public, or really marketing. Occlusion is the common point of dentistry. You know, what do you see when you look at finished cases, the AAO board cases and so forth? You see real finished occlusions. Time is one of our most valuable assets. What's one of the things we run out of first? Usually time and time to do things. This is a major question you have to answer. Are we doctors of medical dentistry or doctor technicians? And more importantly, should we be part of the healthcare team? You know, do we treat teeth only, faces, or people? Do we treat patients, clients, or customers? What do you think is the definition of an orthodontist? You know, should we be responsible for the diagnosis and treatment of any potential dysfunction in the face? You know, I stole from Moss the functional matrix and call it the breathing and swallowing, the effect on muscles, the effect on posture, elimination of habits. And this has to be neutralized, I think. And this is something we have to be aware of. A key point in zero-base is prevention. Awareness of the importance of overall health, or oral health to overall health. You know, dentistry has been into creating great smiles. The prosthetic dentists were into it before the orthodontists, really. But, you know, we've all been working on the outer smile, and I think we should be also working on the inner smile. And the inner smile is a neutralized functional matrix, really becomes the inner smile. And it's the inner smile that really controls the outer smile. So, we have to then neutralize the functional matrix and put balance and harmony in the face. And we do awareness wellness training, which is really part of the mechanics. The transverse change, unlocking the incisors, and getting the case ready, free for treatment, and freeing the TMJ, etc. So, what we're trying to do, you want to incorporate marketing trends. What's going on out there? What do I want to be part of? If we want to be part of the healthcare team, you know, there's a trend. This was in the local paper in Sarasota, but it's really a New York Times article. And your healthcare team should include a nutritionist. You know, if you're doing awareness and wellness training and you're teaching breathing and swallowing, etc., should you be teaching nutrition? You know, it's super out there. Everything you pick up, every magazine, every article, there's many, many things on nutrition and healthcare. We should be into that, particularly if we want to maintain our specialty. You know, it's just Walmart is going into organic foods. They bought a company, they're reducing the price of this 25%. So things are going up out there. Nutritional training, belly fat. They're showing how critical belly fat is to overall health. You know, as we're teaching oral hygiene, as we're teaching patient care, we should be teaching nutrition. And a growing problem of obesity and bad nutrition. So, with the awareness training, we're doing nutritional training. The importance of having a well-balanced diet and how to evaluate a patient's teeth, so forth. But nutrition is becoming a super important thing. It's a trend we should take advantage of. This is a book that a man in Sarasota, he lives between Sarasota and Chicago, has come up with, that I think is a great book. And he's written 4 books, and he's written one on healthcare. But he called it Entering the Shift Age. We're living in a new millennium. We're living in a new century. We've entered a new age, the shift age. We've entered a new decade that's he calls the transformation decade, from 2010 to 2020. You know, we've been through the agricultural, the industrial, the technological, the information age, and now we're in what I was calling the conceptual age, and he calls the shift age, which I think is great. And tools define the agricultural age, machines, the industrial technology, and the information. Consciousness is defining the shift age, or innovative thought. You're going to have to use your imagination, and you're going to have to be thinking how we're going to do better than what we're doing. Different ages often overlap and blend in each other. That does not mean that the advancements of the previous ages go away. So, focus, specialization, and analysis have been important in the information age. In the conceptual age, or shift age, the ability to use seemingly unrelated pieces of information to form the big picture is crucial. Left brain dominance is giving way to right brain artistic and holistic abilities. You know, it's the art of orthodontics. It's really the holistic things that we should and are doing. The current decade is one of transformation. You know, we now live in the shift age, a time of transformation. The shift age is one of those times when much humanity is changing how we live, how we think, how we interact with each other, and what we do. Power has migrated from institutions to individuals due to the explosion of choice. Also, the technologies and dynamics moving us from hierarchies to networks and ever-increasing electronic connectedness. You know, what do kids do today? You know, one-on-one communication to younger people is going to be different than it is to us. And it's going to be there. It's arriving, and it's more and more. He addresses this here a bit. The speed of change. The speed of change is 100 times faster than it was in 2012. Remember, he's talking about the transformation decade from 210 to 220. If this is true, then the amount of change humanity has experienced in the last 1,000 years could be equal to the amount we experience in the next 10. You got to think about that one. If you do, read this book. It's really good. He has what he calls digital natives. These are the high school class of 2012 and younger. Why they are called digital natives? They are the first of all the generations to be born into the digital and information overlaid world. Anyone over the age of 30 in 2012 is a digital immigrant. They come to the new digital world as a teenager or adult. This means that, unlike those over 30 today, digital natives have a hard time understanding why their elders feel overloaded with information. This generation will have a profound effect across the board. Have you embraced virtual communication? You know, it's everywhere we go. We can embrace this, but at times it may still require more in-house contact or communication as the degree of difficulty in a case increases. Balancing the tech overload. The challenging question is, how do we balance the pull of new technology with the essential personal touch necessary for practices to truly thrive? With the incredible focus on technology and advancements in treatment practices, it's easy to forget the importance of real human relationships, but they may be different. It's the human touch that we all need. One-on-one communication. One-on-one communication is going to change. Our job is to shift the focus from strictly technology to superior communication, personalized care, and relational stability. which may be different than the way we thought about it in the past, though. We need to make technology a benefit to us, not the concept that defines us. Your view of the future shapes your actions today, and your actions today shape the future. Progress is impossible without change, and those who cannot change their minds cannot change anything. Change is inevitable. How do you prepare for change? You know, do we naturally resist change? You know, girls, when the doctor goes away to take a course, they're worried when he comes back there's going to be major changes. So we're built to resist radical change. Our nervous system wires us for resistance to a big overhaul of any kind. Kaizen, which is really a Japanese word, and it really goes back to Deming, which I can't take the time on now, but it's change and it's good change. It's good change or improvement, or continuous improvement. Business culture loves the idea of revolutionary, immediate big change. But the turnaround efforts often fail because radical change sets off our brain's fear response and shuts down our powers to think clearly. Kaizen is a more effective path. To change begins with the small steps of Kaizen. The small steps bypass our mental alarm system, allow our creative and intellectual processes to flow without instruction. The result, change that is both lasting and powerful. Key point, to enhance the zero-based bioprogressive philosophy by evaluating and monitoring the practice of orthodontics in today's rapidly changing times, going from analog to digital. You know, we use the bell curve, and I change the center line to neutral because I don't know what normal is. And so this is how we establish a degree of difficulty. You know, everybody has a center baseline. And we're all individuals. And everything is individualized. So 70% of the cases we can treat with most anything, not always getting the best result, but we get into the other 30% that are the difficult cases. We have to be able to determine those. So, as an example, you are personalizing how the patient fits into the various systems in your office. Whoops. That was a bad one. I've got a new thing here, which I don't really, I forget to push the wrong. But you know, as we think about change, let me get where I'm supposed to be here. Okay, the communication system. The more difficult the case, the more communication needed. In other words, in your systems, this is what you need. So, we use a management system of the what, the how, the why, and the if. Everything you do in an office, you gotta know why. And even a wire. What's the wire? How do you use it? Why do you use it? And if it works. So, what's really difficult is the operating elements of a practice. You need the skill to balance these elements. So the management system leads to 7 technical systems you need in a contemporary zero-based orthodontic practice. Each system has a zero baseline based on degree of difficulty. For sure, you need a diagnostic and treatment design system. You need a communication system for total office communication, marketing, awareness, wellness training, practice training, office and staff. And this is all a zero baseline. Imaging, visual treatment chart, a patient orthodontic diary that you're developing as you go through treatment. So visual treatment planning, scheduling system, a statistical system along with your financial system, a biomechanical system of mechanical flow. So these all lead to coming up with a biomechanical system that really, to make it function in an office, you need to be doing all of these things. And this is where, you know, quality can really be done in a franchise-type office, if you'd like. And the example, you know, this is a case from Dr. Hiroshi's office, which is really a zero-base office, and where many of these things are carried out on a routine, daily basis. But, you know, using all the technologies that we have, you know, he mounts all his cases, all mounted study models. Now, the cone beam is coming in, though, we can have a virtual articulator. But, you know, we've been using the axis orbital plane to tie the cephalometrics to the articulator, doing a centric relation VTP on a difficult case. These are his objectives in this case, and this is his treatment plan, or his treatment design. So, and then using the cone beam, and this is the systems he uses to distalize lower molars without extruding them. And so, high degree of difficulty case. See, but if you can set up the systems to treat high degree of difficulty cases, you're going to treat the easier cases much more simply. But look at the kind of, this is the kind of work that can come out of a really organized, zero-based, bioprogressive office. Here's the case after 4 years. So this is really the type of thing. And you know, with this type of a system, you can really say where you want to go, and then you can say, did I get there? And see how close you did by looking at your superimpositions, etc. So you need these systems to really carry out a high-level office. So let's continue to keep growing to revitalize bioprogressive today and in the future. And thank you all for being here.